we'll just, so we've got the panel and so Deb, you've got a microphone ready. Do you just want to give a reflection on what you've sort of thought of the session, what you think were some key questions that you thought were coming up and some points, and then we'll go through the panel and we'll get Catherine as well, and then any questions from the audience, or remember to text them through, so we'll get them through. So thank you.
Sorry.
Yeah,
Oh, I thought the audience participation was fantastic. I think they all made some really good points, and I think it's a very useful exercise.
I think it was a little bit different being an online moderator, particularly having to sit there for 15 minutes while they all filled out their forms and not say anything. But there were certainly some interesting questions coming, and I think the most common one was about rabies schedules. And you know, there were a number of people asking about the 0 and 7 schedule for rabies, and can we do it because it's cheaper, and this, that, and the other. And I think, as was said this morning, ATAGI are currently in the process of updating it. It's likely to be completed, I heard from Catherine, that likely by the end of this year, that we will hopefully be going to a 0 and 7 schedule. But until it's actually formally announced and in the immunisation handbook, we really need to stick to doing what is recommended, and then hopefully by the end of the year onwards, we will be able to go to the 0 and 7 like many other countries around the world. Whether or not we're going to still need a 12-month booster or not, we don't know. Obviously, WHO doesn't require that, but as you know, with the current recommendations in the AIR, the 12-month booster is recommended if you have a rapid course of 0, 3 and 7. They're recommending a booster at 12 months. And whether or not that will still stay, we don't know, but it looks as if, from what people are saying and from reviews Deb and I were involved in as well, that hopefully 0 and 7 is going to finally happen.
Yep.
Sorry, just to add one thing. If people have had 0 and 7, they still need to get boosters after the bite. If they have an animal exposure, they still need to get their boosters day 0 and day 3.
And a common theme, and I'm just getting some further questions online, is what's subsidised, as in there's this National Immunisation Program, there's the state programs, and what's free is a question, and also is a issue as to what's recommended and what's funded. And then there's a question about what it is we think is the Rolls Royce, and what it is we think our patients can afford. So another question on the panel, and then I'll go to the one from the floor. Yeah, just comment on any final thoughts, the questions that were being asked that you didn't get a chance to answer. Or...
Yeah, I thought all the questions were really good, and as they said, the audience participation has been great, and I really love getting questions because it is quite a tricky area. About all the funding, it's quite complicated because of the state to state. I think Deb said that the MMR is not funded. I thought it was, but it's Victorian government funds it. And I thought it was the Australian government. So in other states, it may not be funded from 6 months of age, but in Victoria, it is. So that's sort of one state thing. And with the NIP vaccines, the way I interpret it is that Medicare, and it does say it quite strange on the Health Australia website, it talks about Medicare eligible families being funded, but then it goes down and talks about children under the age of, I think it's under the age of 20 being funded, and it doesn't talk about Medicare eligibility. So I take that as catch-up vaccination and that it's free.
Thank you.
Sorry, can I quickly say something?
Yeah.
Yes.
Yeah, sure. So I think I totally agree with the comments. I would go on your state health websites for clarification of funding. In SA, where I'm based, it's different from Victoria, and they like to make it really confusing for us. So I would recommend anybody who is interested or is in immunisation is to clarify those points on their state health websites. It seems that Victoria likes to give lots of things funded. I don't think we're as lucky, although we have meningococcal B here in SA. So I just need it. Yeah, it gets confusing. So yeah, I will just verify that.
Hi, so I just had a question about rabies. I have a person who works with bats who's just had serology done for work. They've had a full course of the rabies vaccination because they work with the bats, but the serology has come up that she needs a booster. So what would be the scenario? Because it's quite complex from what I could see. I've said to her that she needs one booster and then serology to check that in, I think it said 12 months. I'm trying to remember.
This is a very good question for the bat carers. You would need to know when their course was. So if their course was 3 shots, but how long ago?
3 years ago.
Okay, so when you do the level, it's probably going to be lowish. You would hope they haven't had much exposure in the meantime. So I would look at their level. Now, is their level 0 or is it just lowish?
Below 0.5.
Under 0.5.
Yeah.
So then what I do is I do a booster and I do another test in about 3 weeks. We did a study where we looked at all the bat carers, and about 2 to 3 years is when you normally routinely want to boost or test people if they've had their 3, because you need much higher levels for bat carers because they could have inapparent exposure. The bite of the bats is really tiny little teeth. They could get a bite without realizing it. So I would expect that if they've had a booster and a blood test, that they will come up very nicely. And then they will just need to have another test in a year to make sure the trajectory of their antibody levels is okay. And then after that, every 2 years.
Thank you. And when I was on ATAGI, when we threw around a discussion, a lot of the people on ATAGI said, don't bother about any vaccines because you still need your immunoglobulins when you get bitten. So wait until. So there's a difference of no. I know that. Well, people say is it, and we talked, accept that we talked about the scenario is 3 weeks of a risk, is 1 day a risk. Can you get off the plane? So when you discuss it all, so some people even say, look, you got to treat it anyways. But I'm kind of in the camp that says you should be vaccinated, but there are differences of opinion. So Lynn, yeah, and then.
I think it's not just a matter of talking about whether or not you're vaccinated. I mean, one of the main things with travellers is if they're bitten, can they easily access the post-exposure treatment? And that's the issue. I mean, even in places like Peru, you'd think that they would have post-exposure, but they don't. So they don't have the immunoglobulins. So you can't assume that you'll always be able to get treatment. And that's why it's so important for travellers to think about getting vaccination.
I was really impressed about the level of knowledge, and we were really just coming to a consensus about what were some complex questions about talking to patients about who are vaccine hesitant, and then negotiating on catches up. And so I think we started with really good concepts, and that has sort of proven to me that most of the clinicians, certainly in my room, probably through the pandemic experience, had really started to sophisticate their approach to vaccine conversations. And there was a general acceptance and acknowledgement that apart from that small percentage of people who are truly committed to being totally anti-vaccination, that there are really relevant concerns that you can work your way through fairly methodically. And I think we've honed those skills. And there were some really sophisticated ways of having those conversations. So I think that the pandemic has given us a lot more skills than perhaps we realise. So I also think that from the travel point of view, we're not as rusty as we think, even though we have been sending people overseas for some time. The level of knowledge was excellent. And we were talking really about the art of how you design a schedule of vaccination, how you design a travel kit, how you give advice that is bespoke, having an awareness of guidelines and an awareness of what is recommended, but then talking to the patient and getting down to as much detail as you can. So the advice you give is as bespoke as you can, because this is not protocolized medicine. This is really understanding what each person's doing on their trip and then coming up with a program for that trip and that person.
And I'm just wondering, Catherine, if you want to add to that or any summary. You're online, and how you think it went, and maybe touching on what's a question I've had from online is other things other than just the vaccines, which Anita was just touching on, but some of your comments around the things other than the vaccines that we need to do to look after everyone.
Yeah, I echo Jenny's comments in regards to having a workshop online. It's quite lonely when you don't get that feedback, that discussion. So you're hoping everybody's listening. But there were some really good questions coming through, which hopefully we've answered most of that. I was trying not to put my travel medicine hat on and let Jenny answer those questions, which was really hard for me. About rabies and so forth. And in regards to travel medicine, totally agree. It's not just about vaccines. Travelers quite often come in and that's about what vaccines do I need? It's all about the other stuff, the water safety, the insurance. Do they have adequate insurance? If something goes wrong is so important. In regards to vaccines, there's a lot of questions about egg anaphylaxis and MMR and flu vaccines. I did highlight the Australian Immunisation Handbook, which is kind of the go-to with any of those questions as well. But overall, really good question, like lots of good questions coming through.
Yeah, can I just comment on the egg anaphylaxis? In my scenario, I deliberately put in that the 14-monther was allergic to egg, anaphylactic, just to see if it would draw any questions, and it didn't. So children, and I'm sure Catherine touched on this during her case, but MMR flu, very safe to be given to all children and adults, regardless of egg allergy status. And we give them quite easily in a community setting, wherever it's safe to give. We do get that question quite a lot over our phone lines.
Actually, one thing that came up in our group too was just the very simple but important idea of the financial consent when you're dealing. We did use the Google for a couple of the cost of some vaccines that are available, and I think that that's part of our conversation, that we've got to get the informed financial consent. And then one of the conversations about people who choose not to vaccinate is the informed refusal. So do you know what polio is when you're refusing a vaccine? Do you know what you're refusing in terms of the risk and what the disease actually is? Because we acknowledge that a lot of modern Australians, particularly young modern Australians, actually wouldn't be able to conjure up in their mind what diphtheria or polio actually is.
Can I just add, I think that it's really important that as travel medicine providers, we don't make decisions about the financial status of the patient, that we allow the patients to make that decision. And many of these travellers are spending enormous amounts of money going on their trips. And yes, they might blanch a little bit when you say the vaccine's $300, and you obviously do need to give consent. But if you're paying $300 to stop a disease which is fatal or incredibly unpleasant, then that may be something that is of value to the person. And so I think it's really important to actually let them make that decision and remember that it's value, not cost. Like, nobody wants to throw $300 down the toilet. But if you're getting a vaccine which will last you for the rest of your life, it will stop a disease like Japanese encephalitis, which is untreatable, rare but horrific, leaves you with brain damage. Maybe that's of value to a lot of people. And when we did our study looking at who thought it was valuable, the people who we surveyed 1,000 charts during the pandemic when we had nothing to do, and we looked at who needed Japanese encephalitis vaccine. We did publish it, and whether or not they did, and what were their demographics. And what we found, that only about 24% of the people who went to a JE area were vaccinated, and a lot more of them were workers, so their company was paying, or students, so their parents were paying. When the individuals had to pay, they didn't they could make that decision, but the others were getting it paid for, and they said, yeah, sure, that'll be good. So I think we have to be a bit careful about cost and letting patients make the choice about cost. Our job is to give them the information, to tell them what the value is, and then they can decide.
So I've got some questions online. So when you're doing catch-up vaccines, are you doing a catch-up vaccine to satisfy the rules of the place you're about to go, like kindergarten or school? Or are you giving advice to tell people how they'll be most protected from most diseases that they need in Australia? So anyone like to talk on the catch-up? So I think Anita and Lynn, you get the score on there.
Yeah, it's a good question. And look, a lot of the families I see are only being vaccinated, not a lot, but some are only being vaccinated so their child can attend childcare or kinder, or they can get payments. And that is their sole purpose. So that's the discussion. When I talk about these alternative or minimal schedules, it's definitely not my first preference. My first preference is a national schedule from 6 weeks of age, follow it. That's my recommendation. But with some of these families, it's about trying to get them across the line. Any vaccine is better than nothing. So that's the way I approach it.
This came up in our group, and I love the definition of what evidence-based practice is, which is what the clinical and evidence is. It's the experience of the clinician, and it's the values of the patient and the context of the patient. So that's what evidence-based practice is. So I think that we have to appeal to what is valuable to the patient. So if one of the key drivers for a patient is the going to kinder or getting the payments, that opens a conversation. And then you can add in other components from the medical agenda. But I think we have to recognise that we have to meet the needs and the values of the patient and what is important to them. And then also take the opportunity to do the education about that you would see more as the clinician's agenda.
There was a question that I was just showed by Rod about the tick encephalitis vaccine. It is available in Australia. It's only available on the special access scheme. So it's not like a normal vaccine that you would buy from a pharmacy. You have to fill out a little bit of paperwork. And there are two suppliers for these kind of specialised vaccines. One's called Link Healthcare, and the other's called HL Pharma. And I just can't remember which one supplies the tick encephalitis vaccine. But basically what you do is you fill out this paperwork and then you order the vaccine in, and then you can supply it to the patient. It's certainly not something that's commonly needed. The other thing is that the normal schedule is 0 and kind of couple of months and then 6 months. But for Australians, they don't have a lot of time. So even one dose of the vaccine before people leave the country would be useful, because they can get the second dose in Europe. It's readily available in Europe. And there is a shortened course for tick encephalitis where you have 2 doses given 14 days apart. And that's enough to give people protection for 6 months, which is sufficient for people doing orienteering projects or bushwalking in high-risk parts of Europe. So at least having that conversation with people. If you drop me an email, I can tell you exactly which supplier it is. But yeah, it is readily available.
We'll make contact details available, and you'll see these talks and the people's contact addresses on the Immunisation Coalition. So Catherine, while I've got you online, so when you catch up people or recommend, are you doing it for them to go to childcare, or are you doing it to get the best value? And then when people are travelling, you think broad advice on the non-vaccine alternatives?
Yeah, I totally agree with Lynn, and when she smiled when she heard that comment, that you want to do it for the right reasons of vaccinating the children, but at the end of the day, I will take any opportunity to vaccinate that child. And it happens all the time that they're here just to be vaccinated, just to get the certificate so they can go to kindy, which is that you try to, obviously inform consent, discuss the reasons and behind it. But at the end of the day, if that's the reason, then if that child is vaccinated, then I'm happy. It's happening, yeah, in the last few years, it happens all the time. And quite often I also find that vaccine hesitant parents, they also want to have one vaccine at a time rather than having all the vaccinations at the same time. And obviously you have to discuss that with the patient and the parents, in regards to trauma to the child. You know, it's more traumatic for the child if they kind of coming in every few weeks for a vaccine. So it's all about those communication skills, getting the parents to be confident in you as clinicians, you know, a regular face, and giving them the ability to think as well, and no pressure. I actually find that, you know, if they feel, as soon as they walk into your room, you can almost feel that kind of like, I don't really want to be here. So it's really important for them to be confident in you, and then they can say what they want. They can say, you know, how they feel and so forth. Sorry, in regards to travel medicine, just repeat that question.
The non-vaccine guidelines, what's the 2 or 3 tips you say to people for all of the non-vaccination things, like keeping your hands clean? I need to
Yeah,
drink out of
so number one is always travelers' diarrhea. You know, we can get gastro anywhere, obviously, in the world. There are places that we're obviously more concerned about. So food and water hygiene is really important. Just getting back to basics. Don't assume your traveler knows not to, you know, drink the local water or put the ice in a coffee. I also think handouts are fantastic. Sometimes, you know, you have travelers come in who are going to South America and they're leaving tomorrow, and you think, oh, all this information I have to give you. And after 15 minutes, you get kind of a glazed look because there's so much information you need to give them. So I also think handouts are really important. And you know, they can contact you afterwards. So if they kind of feel they want to ask you more questions, is really important as well. But food and water hygiene is, you know, really important, as well as water safety and you know, RTAs, mopeds, making sure you don't go on a moped, and if you're going to go on a moped, put a helmet on, insurance, and all the kind of basic things that we talk about. All these diseases that are obviously very important, but just getting back to basics as well.
Thank you. You touched on getting in contact later, and Anita, can you perhaps start, and then to Lynn and the others, about feeling comfortable to say, I'll design your vaccine program and your advice separate to this consultation, and the advantages of that and how you use that. So Anita, maybe you start with that, and then I'll ask Lynn, you design these vaccine or catch up, and then the others, that how much do you do at the time? How much do you just do the hand up, or to get them back and do it? Like, what's your thoughts on how to manage that and get the best out of?
We said in our group, I'm just so grateful that I entered general practice in the era of general practice nursing, because I wouldn't design a catch-up program without consulting the nurse. And I think 2 heads are often better than 1. And I think that if it's a complex catch-up, trying to do it in real time with the patient in your office, you're likely to make a mistake. So I think it is something that you take offline, as they say, and say to the parent, I think you impart the information, the education, the principles, the negotiation, etc. And you may be able to do the first of your vaccines or whatever. However, I think that really designing the catch-up, particularly, as we said, when you're catching a child up, they are growing up, and you've got to think about the timing and the number of doses. That's not simple, and there's a chance for error, and also the costs of some vaccines, as we know, they change over time. So I think it can be certainly 30 or 60 minutes worth of work doing this properly, and I'm very grateful that the nurses really take on the majority of that work. And I think that parents are accepting of that because they know that you want to get it right. So I think that the consulting component is the agreement and the education, but the nuts and bolts takes a little bit of quiet contemplation.
Yeah, so in my setting, obviously, I have time to sit with these families for extended periods, which is not possible out in the community. When I do very specific plans, personally, I will always give them my email address at work. And I tell them, you know, a lot of families will go back and ask their GP to continue on with the plans. Some GPs just go, I can't do it. And that's okay. Some clinics will just refuse to do anything but the national schedule. I can see why, because it's difficult and errors can happen, and that's sort of what I tried to go over in my presentation. Which is why I always give the families my details and say, if you have concerns or questions, or if your GP is concerned, please give them my email, get them to contact me. I can talk them through it. If you're moving through the schedule and you're sort of a bit unsure, just email me, because I can always access their air and see where they're at. And that's really just to try and minimize any confusion or errors happening down the track. And some families do come back to me. Sometimes we'll do a schedule sort of starting at 6 weeks to 12 months, and then I'll bring them back and we'll review them at 12 months and we'll do the schedule from there. It's really personal case preference and what the families want to do. So a lot of my plans are very individual, but I will always give them my details and offer review appointments as well. And I'm more than happy if you ever see my email on the bottom of a letter, just email me if you're unsure. It's completely fine. And my colleague Sonia, who also does them, would be more than happy as well.
Yeah, well, I think it obviously depends on what vaccines we're talking about. I mean, travel vaccines, often we only need to do them on the day that they come in. And then if I'm giving a course, for instance, if I decide to give someone 3 rabies vaccines, then I'll actually spread the others across the 3 visits so that they're not having too many on the same day. So it really depends on what you're giving and how many times they're going to need to come in, and the number of vaccines as to how I would do it.
Can I ask a question of these esteemed colleagues? With the topic of monkeypox has sort of now also been, it's not as mpox, and there were no examples of men who have sex with men in the case studies. And I'd just like to hear your advice for GPs doing travel consults for men who have sex with men, with regard particularly to that vaccine and what our approach should be, because it's kind of exited the conversation in the last 6 months.
I think I have found that the majority who fit into that category have actually already had it when they come in. And then there'll be those that will come in and usually they say they're on PrEP, they've got PrEP, and you then ask them more questions, and if they haven't got it on their AIR, then it's obviously unlikely they've had it, and I will then have a discussion about it. But I have to say the majority of them have, in my experience, have actually already had the vaccine.
I think this is a tremendous question, because it is something that we will always raise. Have you thought about what happens if you get diarrhea? That Catherine has raised. And I think it's worth, saying to the patients, have you thought whether you might have any new sexual partners while you're away? Did you want to talk about that? There are some things that we can give you. There's actually now some data to suggest that maybe doxycycline is quite useful for prevention of some sexually transmitted diseases. Gonorrhea and syphilis are all roaring. So I think it is worth opening that conversation with that. And I think mpox is part of that conversation.
And online, Catherine, did you want to add anything, mpox or
I would
some of the other
echo
points?
Jenny's points. The travellers that I've seen have already had the mpox or the vaccine. I would also just not assume that STDs can only be caught in the young people off to Bali. School is weak. Obviously, the research is growing in the more elderly population as well. So in our job, we can't assume anything. And you need to have those frank talks, about, taking some condoms with you and sexual health in all the age groups. You have to, obviously ascertain the risk level during your conversation. But you can't assume anything.
Thank you. And doxycycline was mentioned, and we did just have a question online asking about malaria and doxycycline. Did you just take it anyway? So we were told that mosquitoes don't fly high over the mountains. They don't go down by the beach. They live in the middle, or did I get it wrong? They live in the beach. So comments about doxycycline if you're not sure, and which mosquitoes do you worry about, and is it only all around all seasons? So comments about.
Yeah, well, malaria is a very complex area, and I think it's important if you're advising as a GP somebody who's going to a particular area that you're aware of where the risk areas are. And, you know, each country will have areas that are a risk and aren't a risk. And there's various websites that you can look at that will give you information on malaria. And that's one of the big issues with travel medicine, is that there is quite a lot of variation between, say, the US CDC website and another, say, European website like Fit for Travel in terms of their risk. And I think in Australia, we tend to probably sit more towards the European side of things. We try to use a little bit more in the way of prevention and things like that. But you know, if people are going to a malarious area, then I think it's important to take malaria prophylaxis. We used to give doxycycline out like lollies years ago, and I have to say that the amount of times I give doxycycline out now is gone down to extremely low levels, and I would use Malarone much more commonly than most. In terms of where the risks are and is it seasonal, yes, and there's certainly parts of the world that its seasonality is extremely important, like some of the West African countries. So, you know, it's really important to know what time of the year. Are they going in the wet season or not? Risk in Africa is, in many of the African countries, is far higher than if we consider risk in some of the Southeast Asian countries. So it's not an easy topic, and there's no one size fits all. And if you're going to be a travel medicine provider, it's something that you need to have a lot of knowledge about.
Look, I think that I would agree what Jenny said. It's not something we can deal with in a 5-minute question. There are resources available. They're not free, and they give information, very detailed information about seasonality and regions and so on. And I think if you don't have that information, what do? You can't guess. You've got to find out. Yeah. And I agree, we've given a lot more Malarone. We're giving a little bit more Tefenoquine now, I have to say. Very occasionally might use Larian, but almost never.
Thank you. So any questions from the floor? So if we can have there's just here, there's one there and one here. So from the floor.
Is TBE vaccine available in Australia?
Yes. I think I answered that just earlier. It's available on the special access scheme, and you need to fill in the paperwork, and then you have to order it from the supplier. Or the easiest thing is probably to send them to a travel clinic, because they're honestly doing that all the time. But it is definitely available for people who are at risk.
Thank you.
TBE and encephalitis vaccine, yeah.
It's not cheap. It's if you're doing 2 doses on someone before travel, $750 for the 2 doses.
Thank you.
Another question here, and then another question there. Thank you. We've got other questions here. Yeah.
I have a question regarding COVID treatment. There's an elderly person I know of, she's nearly 80, who's been testing positive for COVID for the last 4 months or so. And her practitioner has been giving her treatment tablets every fortnight, an antiviral script. And she continues to test positive, but her PCR is negative. She had a negative PCR yesterday, apparently, so I've been told by the family. But her rat test positive. I mean, what does that tell us?
I think if the PCR is negative,
the PCR is negative.
Yeah, if the PCR is negative, she's negative.
Yeah.
The PCR is much more sensitive than a rat test.
Why is that still positive though?
Well, I think Gary put up the slide that the WHO says that at 6 days you're not infectious from that particular contact. WHO is quite confident about that. Each state made up its rules, like we went through COVID, and PCR can test positive for a long time. So fragments of the virus can be excreted, and that rapid antigen test can be falsely positive. So the advice is from the WHO is that that particular infection isn't going to be transmissible after 6 days.
I think also the rat tests have to be treated with a bit of suspicion. They're not perfect. They don't, they can expire. It can be wrong. I think that you would ignore the rat test if the PCR is negative. I also think there's not a lot of evidence for continually giving antivirals.
No, I
I
just,
think you're right. I agree with you.
I just needed to know for them really. And occasionally she has a few symptoms and she's concerned she might be contagious. So she's locking herself up in a house and not seeing people if she's not feeling
Yeah,
it.
the clear advice from the WHO is that it's not infectious. I guess there's a risk of another strain coming through, which is a fairly small risk, but it's non-contagious and the continuing positive shouldn't be looked at. So another question there, then another one over there. Thank you.
My question is in regards to the websites we can find about the malaria areas. How can we find them? I've tried in the past to go through different websites. For example, I remember Vietnam, and one part is here, malaria positive. It's just kind of mind-boggling. It's so difficult. So I was just interested which are the recommended websites for checking about malaria. I find that's fairly complex at some stages.
Yes, so I've got a similar question to her about the seasonal variability, like which website you would recommend for us to check out malaria and so that we can recommend it to our patients.
The one that I personally use, I have no shares in it, is the Shoreland Travex. It's about $1,000 a year. To me, it's worth it, but it's obviously not going to be worth it for everybody. It has very detailed maps and seasonality. Yeah, nice red malarious areas. Yeah. But the other one that's free is the CDC, and that's probably the best one. I don't know if you've got any experience, Jenny.
Yeah, I do find the CDC one is very conservative, i.e. if there's malaria in a country, you'll often find the whole country shaded. So I find that one a little bit, yeah, it's a bit over conservative, but Fit for Travel is not too bad. That's NHS UK. That one is pretty sensible in recommendation.
Okay, so thank you very much. I really appreciate everyone's attendance. I really appreciate the panel's involvement for this final part, and thank everyone who's still sitting here in the audience and all those online. So there's been huge attendance online, and thank you.